Well, there were several that are very relevant to hematologists as well as cardiologists. The first is if we look at child and young adult cancer survivors, and this is people diagnosed with a cancer under the age of 25, which includes a lot of Hodgkin lymphoma patients, of course, that there's been a further update of the harmonization of the late effects of childhood cancer and who needs monitoring for lifelong follow-up. And this actually maps very nicely to our ESC guideline in terms of the total doxorubicin dose or equivalent, the total radiation dose, and then the frequency of lifelong surveillance. So that's the latest International Late Effects of Childhood Cancer Guideline Harmonization paper that was published last year. Then there was a further meta-analysis regarding the role of dexrazoxane in preventing anthracycline cardiotoxicity. And this has been a controversial area because initially some of the studies had suggested there could have been a problem of increased risk of second malignancies, possibly interfering with the treatment of the initial malignancy and some bone marrow complications. But it turned out that those were really relevant if people had an unusual combination of 3 topoisomerase inhibitors, so an anthracycline plus a topazide plus the dexrazoxane, which really doesn't exist now in modern oncology and hematological-oncology care. And so this sort of meta-analysis took a whole group of different studies that had been performed at Dana-Farber in Boston and included both acute lymphoblastic leukemia patients, lymphoma patients, as well as some other non-hematological cancers such as sarcomas, and where the patients had had a follow-up of for 18 years or on average, and what the impact of having dexrazoxane was at the time of their cancer treatment. And it proved that it significantly reduced cardiac abnormalities at long-term follow-up. So again, more evidence that dexrazoxane is cardioprotective, both in these late and long-term effects. Another trial that was published last year was looking at the role of statins in a prevention of anthracycline cardiotoxicity, and this was called the STOP-CA trial. Was performed in 300 adult lymphoma patients, the majority non-Hodgkin lymphoma, so probably older and with a range of probably increased vascular risk as opposed to the younger Hodgkin lymphoma patients. And the patients were randomized 1-to-1 to atorvastatin at 40 milligrams per day or placebo, and this started prior to the first dose of their anthracycline chemotherapy and continued through the treatment and then for 12 months after their final cycle. And they had echocardiographic and MRI surveillance of heart function, and interestingly, being randomized to the statin did have a reduction in LV impairment at this 12-month post-treatment follow-up. Relatively small numbers, 300, so clinical events in this short-term timeline were rare in both groups. So it was really a surrogate with the protection of imaging. Now, that's a really lovely study. I should say that the year before was a very similar study using the same statin, atorvastatin at the same dose, 40 milligrams in a mixed group of lymphoma and breast cancer patients, and found no benefit. So we actually have some conflicting results. So whether we'll need a larger trial or whether we can define who are the higher risk group, maybe the older non-Hodgkin lymphoma patients may have most of benefit if they also have a degree of vascular disease. And then there've been an interesting study looking at how if you can reduce radiation doses, which have occurred over the decades of practice of radiotherapy, how this can change outcomes. And there was a study that was mainly in breast cancer patients, but actually makes the point that with a reduction in the mean heart dose over decades, the incidence of cardiac events and ischemic events was reducing. It still equates to 6 to 7% per gray, as was previously seen in a paper, very famous paper in the New England Journal, where it was about 7% per gray, and also in the lymphoma patients at long-term follow-up, a similar calculation per gray. But if we can reduce the total exposure, then that's beneficial. And finally, there was a paper looking at the cardiac events that were being reported in patients receiving CAR T therapy. And this was a multi-center registry of 202 patients, all receiving CAR T for hematological indications. And a rate of about 16% had a severe cardiovascular event. And of the patients who did get cardiac events, over half of them, just over half at 53%, had died. Obviously, this may be a surrogate for the severity of their cytokine release syndrome, as that's mainly the reason to have cardiovascular complications rather than purely an isolated cardiac issue. But it does show that once the heart is involved in cytokine release syndromes, then the mortality goes up significantly. And so we should think together, working together, how hematologists and cardiologists can pick it up early in order to intervene with appropriate treatments in the higher risk patients.